I'd like to introduce our next speaker, Professor Jason Abbott. Completed his PhD in the surgical management of endometriosis and chaired the endometriosis working group to create the latest RANZCOG endometriosis guidelines. Today we will be hearing from Professor Abbott on the latest advances in endometriosis awareness, diagnostics and management. Please welcome our next speaker, Professor Abbott.
Welcome everybody to this discussion that we're going to have today on endometriosis, and I wanted to talk to you a little bit about the modern management of endometriosis. We're going to go through some basics, but also some areas that I think are important for you to know at this pre-vocational level. My name's Jason Abbott. I'm Professor of Obstetrics and Gynecology at UNSW in Sydney, and I've been a PVOGS ambassador for the last 3 years now. So thanks for the invitation and allowing me to come and to present to you on something that I'm pretty passionate about. As always, I wanted to just put up my disclosure slide, and you'll see that there's quite a number of issues relating to endometriosis. And this is something that I've been working in for the last 25 years, and my PhD was actually in the surgical management of endometriosis and its response and non-response. And I'm the chair of the National Endometriosis Clinical Scientific Trials Group, hold a number of MRFF and NHMRC research funds on endometriosis, and I'm also part of the Endometriosis Advisory Group for Government. So what's endometriosis? And I think this is a really important point, and really the definition that we used to have is under some degree of scrutiny, because we know that you need endometrial glands, stroma, and then you can have hemosiderin-laden macrophages as well. And you need 2 out of the 3 to make a diagnosis, but of course that's a histological diagnosis. One of the things that's important to remember is that what we see in endometriosis is not exactly the same tissue as what we see in utopic endometrium. So the tissues that are occurring outside of the uterus are dissimilar in many ways. We also know that there's a dysynchrony between the menstrual cycle and the way that these glandular tissues respond to hormones that might be present within the woman as well. So you don't always see them lining up, and you don't always get proliferation in utopic endometrium and then in the ectopic as well. So again, one of the myths that I think is really important for us to dispel is that women are menstruating on the inside and they're bleeding on the inside, and that's the cause of all of their problems. That's not how it happens at all. This dysynchrony means that you're creating inflammation. That inflammation then can lead on to specific problems. And we know that at the time of ovulation and menstruation, where you've got not only very high levels of estrogen, but also high level of eicosanoids, that's when you're going to start seeing these inflammatory processes set up, and that can flare situations. But it also tells us a little bit about what you can do in terms of management, and we'll come to that in a minute. Of course, with any inflammatory process, one of the downstream effects is that you're going to have quite a lot of fibrosis. And so we're seeing the emergence of a number of leading clinicians and research groups around the world who are saying that fibrosis should probably be part of the diagnostic criteria for endometriosis. And, certainly back when I trained, what we would see is that we would see white lesions and the black lesions. And I remember my boss saying, you just take away the black stuff, the white stuff isn't really endometriosis. But I absolutely guarantee you that it is. And within that fibrosis, you'll see active glandular materials. So you need to be aware of the range of different ways that endometriosis may present. However, all of that's about histology, and all of that's going to require an invasive way to make the diagnosis, although we have the opportunity to both diagnose and treat, and I think that's important. So if we think about what it is, then we need to understand what proportion of the population are affected by endometriosis. And classically, we've always said it's about 1 in 10. So, a huge number of patients are going to have endometriosis, and we need to be aware of that. As part of the National Action Plan, we did this study, which is an Australian first study, a longitudinal way of collecting data, and demonstrated that in actual fact it's a little bit higher than that, 11.4%, or a 1 in 9 lifetime risk of having endometriosis. And these are with good linked data sets that we've been able to get through the Australian Longitudinal Women's Health Service. It's also important that we identify that that translates to 830,000 Australians who are going to have endometriosis, a really important point for us to make globally. That's 200 million people with endometriosis, so something for us to remember that this is not just an Australian issue, but it is a global problem. And we also know that the greatest time to diagnosis is actually in the mid-30s, and that's possibly because when we're tying into things like fertility and fertility treatments. And so women often will say, I'm not able to become pregnant, but I've had a lifetime of other symptoms, dysmenorrhea, painful intercourse, problems with using bowels and bladder. So with these first Australian data, we've now got very good information to determine our incidence and prevalence, and that's something that I think you can take away, and you can read more on that. So why do you need to care? Well, I think you need to care because this is a very common problem. It affects young women, and these are women who are establishing their careers, their family life. Everything that is happening in their lives can be affected by endometriosis, and it can lead on to substantial mental health issues. It's also associated with other chronic diseases, and I think that that's another thing you need to consider. So problems like autoimmune diseases, although endometriosis is not an autoimmune disease, I think that's really important, but things like asthma, other ectopic diseases can also be associated, inflammatory bowel disease, and also irritable bowel syndrome. We do see unusual presentations, and endometriosis is most commonly described in the pelvis, but extrapelvic manifestations on the bowel, bladder, and then up into the upper abdomen, diaphragms are reported with relative frequency, and then rarely in other locations, but we have found it in places like distal muscles, skeletal muscle, joints, knee, thumb, and even in the brain. So that tells us a little bit about the dissemination of endometriosis, and that it's not just going to be contained to the pelvis. And it's a very common cause for emergency presentation. So I guarantee that you are going to see people who have endometriosis flare, and an acute on chronic flare in the emergency department, remembering that this is a chronic problem, but like all things can have acute exacerbations. And just like we see with back pain, that creates a little bit of tension when these people are presenting to the emergency departments, because no one really knows what to do with them if they're already on background pain medications in that acute setting. And it's an area that we need to explore a bit more. What's the cause of endometriosis? Well, I wish we knew is the short answer. And the first thing I want to say is we call endometriosis one disease, but it's absolutely apparent that it's not one disease. It is multiple diseases, and we just put it all under the same umbrella. And an easy way to think about that is, previously, and when I went to medical school, we talked about breast cancer. And breast cancer was always the same, and it would have the same treatment. You would do a surgery, you would have radiation therapy, and you would have chemotherapy. We now clearly understand that there are different types of breast cancers. These have a different etiological root, and their pathway to treatment is completely different and are going to give you very different outcomes. And I think that that's where we're going to be with endometriosis as well. We know that genetics plays a really important component to the causation of endometriosis, and we've been able to map out areas in the genome where we know that there's strong genetic linkage. And if you have endometriosis, then there's an 8 times greater chance that your daughters are going to have endometriosis. Likewise, if you have endometriosis, then there's a very high chance that your mother or your grandmother may have endometriosis as well. And so we now are starting to work backwards, because quite often older generations simply weren't diagnosed with endometriosis because it was brushed under the carpet. So I mentioned before that, surgery and the diagnostic capacity around histology was the way to make the diagnosis, but I want us to shift away from that. And I want us to think about the parameters in which we can help to make a diagnosis without doing something invasive, and the issues and the limitations around that. So the first thing is history. Obviously, taking a really good history from the patient, working out what their symptoms are. And classically, we see pain-specific issues. We see systemic body symptoms, headaches, fatigue, and gastrointestinal symptoms, and we see fertility-related symptoms as well. Not everyone with endometriosis is going to be symptomatic, and I think that's really important. I've certainly seen cases of very severe disease, even disease that's growing through the vagina, where you have to make sure you're not dealing with a cancer, in completely asymptomatic patients. So the volume of disease does not correlate well with the number of symptoms. Similarly, symptoms aren't either specific nor sensitive to pick up the diagnosis of endometriosis, but they can help point us in the right direction. It's also important to recognise that if you do have many of those symptoms, regardless of what the problem is, you need to address them. And you can't just say, oh, it's period pain, go away and it'll all get better. Physical examination is definitely an underrated area for helping to aid diagnosis with endometriosis. And a couple of years ago, a group of medical students and I did a big research program, and we were actually able to teach medical students to be pretty accurate in determining the site and severity of endometriosis. So they were not much worse than what I was as a clinician. So physical examination is definitely helpful, and you're looking for lumps and bumps, induration, thickening in the uterosacral ligament, fixity of the uterus, particularly a fixed and retroverted uterus, where you've got a lot of adhesions that are pulling things in to a retroverted space is helpful. But really the biggest change that we've seen over the last decade is in terms of investigation and looking at transvaginal sonography, deep endometriosis scans, sometimes using a standoff, so getting a bit of distance between the vaginal probe and the tissues to help discriminate deep invasion into the uterosacral ligaments and the bowel, and we're very good at that, and MRI. In Australia, MRI is not used a lot because there's no Medicare number for it, for this indication, and so we rely quite a lot on sonography. But similarly, those deep endometriosis ultrasounds aren't always available either, so there is a little bit of geographic variation we need to be aware of. So if you're thinking about, my little slide's not going to come up, sorry about that. So the slide that was up was really just around ultrasound, and it demonstrates that on a 2D ultrasound we can understand when you've got ovarian disease, but also in one of the big advantages of ultrasound is that you can use it in a dynamic setting. And we talk about the sliding sign, and the sliding sign is where we start to see the organs and tissues move nicely over each other. And if you can imagine that my hand here is the bowel and my fist here is the uterus, in the usual scenario you would see those two glide very nicely over each other, and then you can understand that there's not any adhesion between the two. But if you've got adhesions, particularly if you've got a retroverted uterus and it doesn't slide, then what you're likely to be demonstrating is there's some degree of fibrosis and adhesion between those organs, and that's when you need to start thinking that there's something else going on. Endometriosis is the most common one of those. We can also detail the depth of penetration into the bowel with sonography, and that's really important if we're thinking about a multidisciplinary team where I would invite my colorectal colleagues in if we're going to be doing a bowel resection if this patient is having surgery because of symptomatic disease. So sonography has definitely changed the way that we view endometriosis. Around the world, my colleagues would universally use MRI. If you're in the United States, of course, you use both ultrasound and MRI, because if one is good, then two must be better. And who cares about the cost? We do, fortunately, and I can guarantee you that you actually only need one. I think that's really important for us to understand. Where we fall down with ultrasound is really in the earlier diagnosis of endometriosis. And we know that if we want to disrupt this disease, an early diagnosis and an intervention, be it medical or something we haven't become aware of yet, might be the thing to do, but we've got to be able to diagnose that. So we're good at diagnosing stage 3, 4, no doubt about that, without surgery. We're getting much better at diagnosing that stage 2 disease where it's infiltrating into the uterosacral ligaments. Where we're no good is that earlier stage disease. Now, is that a type of endometriosis, Or is that a starting point for the progression of disease? Watch this space. I think that's really important for us to understand. One of the things that's important if you're considering a diagnosis of endometriosis is that you want to start thinking about what the patient wants and how they want to be treated, because that's going to really inform you of the different interventions that you might need to consider in this scenario. And so this is very much about shared decision making, but that shared decision making needs to be because of awareness, and you need to offer a range of different choices and treatments. For the patient who has to have a diagnosis, you only have one thing at this stage, and that is unfortunately the invasive laparoscopy with histology. But even that isn't perfect. We don't have 100% concordance, even with that invasive approach. What we don't yet have is a non-invasive way of making a diagnosis, and people have looked at biomarkers, for example, and certainly our group has as well, and we're not yet there. We've also looked at groups of biomarkers and then used that in conjunction with sonography and other forms of imaging, and that's an area of research. So I would expect in the next few years we're going to have a greater understanding about whether we're getting a better improvement in diagnosis using perhaps some of these combinations of non-invasive or low-invasive techniques, because of course using doing a blood test has some invasive element to it. Now, we don't have time to go through absolutely everything today, and I don't expect us to, but what I do want us to think about is, you know, the range of different kinds of treatment options that are available to our patients. And I'm going to very much stick with the medical things. It's not to say that there aren't other options, but I want us to stick with medicine because we're going to be doctors dealing with this disease, but I certainly recommend self-help strategies to women using local heat, which can be very effective for symptoms. Women do describe things like diet, exercise, and yoga, all very helpful for their symptoms, but we don't yet have data on that, but again, we're working on that. My take on those things is they're relatively inexpensive, they're in control of the patient, as long as they're not causing any harm, and particularly around things like diet, knock your socks off. It's when it starts to cost, and yes, you could say going to a yoga studio has a cost associated to it, good, but it does have other benefits as well. So if it's making you feel good, I don't see a problem with that. I do see a problem where we're starting to think about things like treatments where you're having to pay a higher cost, and that might be traditional Chinese medicines where you're creating a tincture and saying that this is highly effective where we don't have the evidence. We know that for Chinese medicines that there is often a good basis for getting improvement, but we have to understand the rationality of that and put that in the same context as we would the pill, progestogens, GnRH analogues. So here what I've got is a range of different kinds of treatments, and I think what you need to consider is for a woman who is 18, 19 or even younger, you know, girl presenting at menarche at the age of 14, if you're going to use a medical treatment, it needs to be something you can use long term. What I can tell you is that the comparative studies between the pill and a GnRH analogue show that pretty much you get the same outcome. It's just that you can use the pill forever, at least up until menopause, but you can't do that with a GnRH agonist or antagonist, and we're starting to see some of those new antagonists come out now. So the mainstay for me, from a hormonal perspective, is very much around progestogen plus or minus estrogen. And so progestogen is definitely what we would do mostly with endometriosis because it's an estrogen-driven disease. But the idea here is that decreasing total estrogen concentration is what's effective. And that's why the pill is so good, because everyone says, oh, but you're giving me estrogen, surely that's going to exacerbate the problem. The problem is not necessarily the estrogen. The problem is the rise and the fall of estrogen, because it's the cycle that's the enemy here. And if you can get rid of the cycle, quite often you'll get rid of not only the symptoms, but also the disease as well. And so we have a good understanding about how the pill works, how progestogens work, and you can use those in any various forms, and they all have advantages and disadvantages, and we could spend another whole tutorial on that and we don't have time for it. But these are definitely mainstays. We've got good evidence that they work. They're generally speaking well tolerated, although compliance can be an issue, and we understand that, particularly with oral medications, 50% of patients will stop within their first year of treatment. We don't see the same with the depots, Implanon, Mirena, and certainly even Zoladex. Although I'm not a big fan of Zoladex for young women, it can have a good effect, but it needs to be carefully monitored because of the long-term issues that can be associated with it. What I want us to consider is just some of the surgical issues. This is a demonstration of a superficial endometriosis lesion that we see in the peritoneum here. And what I was talking about before in terms of, that diagnosis and how we arrive at that. Here what you'll see is glands, stroma, and hemosiderin-laden macrophages in this little black lesion. Those are the powder burn lesions. That's the classic endometriosis lesion. And people always say, well, that's the only active bit. But actually, this is also active. It's biologically active. It does contain glands. It just doesn't have the same degree of inflammatory change. And you often see that this the glandular element here is quite high. And down here, I know the lighting is not as great, but this is also an area of change as well. And so if you're going to remove this surgically, then you need to be prepared to remove this whole area of peritoneum. And I guess, I'm always teaching people about how to make this a little bit easier. And one of the things is, I talk about freeways and roundabouts, and just the vascular changes here. What I'd like to point out is, we've got these lovely straight lines here, which I call the freeways. Generally speaking, no disease in the area. But then what we have is in here, you'll start to see these little areas of vascular change. And those little roundabouts are synonymous with starting to get neoangiogenesis. And these are things that can help point us in the right direction if you can't see where the endometriosis is. Now, that's an example of superficial endometriosis, but this is an example of deep endometriosis. What you see is the tube over here on the left-hand side of the screen. Got the ureter running in here. You just see the ovary poking its little head in up the top. And this is the rectum right underneath me here. Here, deeply burrowing endometriosis infiltrating into this cul-de-sac area. And you can understand why patients might have deep dyspareunia, and even get dysmenorrhea because it's so close to the uterus if you've got this inflammatory lesion in this cul-de-sac area here. But I'm right on top of the rectum. That's it, right in the center there. And here I am looking a bit gung-ho, aren't I? Just tearing off this tissue, actually cutting off this tissue. There's no tearing involved in that. But you've got to get that deep disease out if you've got a chance of the surgery being successful. And it's not for the faint-hearted because it's obviously a high-risk area. Now, at the end of that dissection, it does look like a Rottweiler got into the pelvis and chewed it. And I think that looks wonderful, but patients don't always see that when they're seeing their images. So you've got to go through things with them and get them to understand that you're getting rid of the disease. The resurfacing will take place, and that's helpful. But again, surgery is not the be-all and end-all. The other thing that I just wanted to briefly mention is just around ovarian endometriomas, and this is probably a separate category of endometriosis. It's highly associated with problems that can affect fertility, and we know that the simple presence of endometriosis in the ovary can reduce overall follicle counts. So that means that even in women who haven't had any surgery, that they can get a problem with their fertility. It's one of the main reasons that this is a factor. But if you then do surgery on that ovary, you're further going to reduce that ovarian follicle count. And so what you then need to, and my mantra here is your first go is your best go. And I now extend that to say your first go is your only go if you want women to have a pregnancy. Because in your first go, the evidence is that, yes, you'll get some damage to the ovary, but you may reduce the reductive oxidative species enough that you're going to get decreased inflammation and an improvement in fertilization and implantation. And that might offset the issue that you get with reduction of antral follicle count when you're stripping away that ovarian cortex. But with second and subsequent surgeries on the ovary, key clear difference here, what we do know is that you substantially decrease the opportunity for future pregnancy. So, you need to start having some discussions around doing things like IVF. And I've very much changed my practice over the last 2 decades, gone from being a very gung-ho surgeon and always getting the disease, and now just having a conversation with patients and going, yeah, we can take that out, but there are some issues and some risks. So you need to balance that out. And of course, doing things like an antral follicle count on a scan or an AMH level can be helpful to guide a patient and know their starting point. And that might be a driver for how you get improvement and whether you make a shared decision-making approach to what you see here. And this is a pelvis, again, with a very substantial inflammatory process. What you see pouring out of that ovary, that rich Cadbury's old, gold, beautiful, dark chocolate, which is why it's called a chocolate cyst. And that's all inflammatory tissue. And that's one of the reasons that we start seeing these problems in terms of women not becoming pregnant. Under the ovary, we get all of these structures like the ureter. You've got to be very careful here. And you can see I've really substantially volume reduced that ovary, and that's where we're going to start to see some of their problem. But importantly, you must remove the disease under the ovary. So you've got to be very competent and confident at sidewall dissections so you're removing the disease. It's not enough to simply get rid of the disease in the ovary because you're leaving most of the disease behind. And then you're not going to get a recurrence. You simply have persistence. And that's a completely different kettle of fish. And it's one of the things that you need to consider when you're talking about patients. So in the last few minutes, and I know that I've only got about 3 minutes left to go, and again, we could talk all day about endometriosis. In fact, I do talk all day, every day about endometriosis, but I can't give you everything all at once. We'll have to come back and talk about it again. I just want to go over some of the evidence around things like surgery for pain. And there's 2 double-blind randomized placebo-controlled trials, and these are now pretty old. The first is from Chris Sutton's group and the second is from my group. Both now heading up towards 20 years old. Chris is actually getting towards 30 years old. And these showed that removing endometriosis across all stages of disease was beneficial to reducing pain symptoms. This wasn't a fertility study, it was a pain study, but we do have a fertility study. Sylvie Marcoux and Rudolf Merhoff from Canada did the EndoCan study published in the New England Journal of Medicine in 1997, which also showed that removal of endometriosis does improve your chances of expectant pregnancy as well. Controversial study, but certainly out there and has never been replicated. So unfortunately, these 3 studies, the EndoCan studies and these 2, have never been repeated since that time. So it's a little bit disappointing, but it's one of the nature of doing these very, very difficult studies in a very controlled sense. Some of the take-home points, though, from those studies was that 20% of women don't respond to surgery. So we do know that that non-response rate is also important, and we don't have time to go into the details of that, but I start to talk about the effects upstream and downstream of endometriosis and lesions. And so in inflammatory processes, of course, you get that elevation to the brain. All of the processing is in the head, so pain is always in the head. That's an important thing to consider and get your heads around. And so thinking about strategies that might change that to get some improvement, but also downstream things as well. So thinking about other structures that could be affected, and the pelvic floor musculature, the bones, and even the nerves as well at a more local level. It's also important for us to remember that there is a placebo response from everything we do. So whether you're giving a patient a pill or whether you're doing a surgery, there is between a 20 and 30% chance that anything you do is going to be due to their placebo response. So you must make sure that what we're doing is going to have an improvement above and beyond that. And that's where placebo-controlled trials come into their own. We have an increasing number of them in surgery, and we've started to demonstrate that surgery isn't great for everything that we have in medicine. We do have these studies in endometriosis, and I'm hopeful that we'll be able to complete some more of those in future. So that looks like I'm at 29 minutes, which is perfect timing, a place for us to end. So if I was to kind of wrap all of that up, I think the key points that I want you to take home from today's discussion is to think that endometriosis is incredibly common, and if you're going to go into women's health, be it in primary care or in O&G, you're going to come across this. Be aware of it, understand it, and don't be afraid to talk to someone if you don't have the depth of knowledge. Identifying that whilst we talk about endometriosis, it's probably a range of different diseases that we've not yet quite got our heads around with different causes. A huge factor in that is genetics, and understanding that may be the key to getting some improvements, not only in diagnostics, but also in therapeutics. And we've definitely seen that in cancer fields, and I hope we see that some translation of that to endometriosis in future, and we're definitely working on that. In the area of making a non-invasive diagnosis, history, examination, investigation is imperative, and imaging is really important. And getting a positive test, so seeing some disease on imaging such as ultrasound, is very likely to give you the correct diagnosis. But a negative laparoscopy means that a negative ultrasound means that about 40% of the time there may still be a diagnosis of endometriosis, so that's important. In terms of where we would go to after that, find out what the patient wants, where she is in her life cycle. Is she thinking about managing symptoms, or is she thinking about fertility, because the treatments are going to be different? Optimize things like the self-care things, as long as they're not going to be harmful, either from a health perspective or an economic perspective. And then think about simple things. Analgesics, hormonal treatments, again, go for simple, something that can be used long-term. Think about issues and side effects. And then surgery only in select circumstances. We definitely need to move away from this concept that everyone who thinks that they might have a diagnosis needs to have surgery. And if we've made the diagnosis of endometriosis purely by chance on imaging, but the patient has no symptoms, they don't need an operation. Remember, there's issues and limitations with surgery, so you want to think about non-responders, why that might be the case. You also need to think about having a placebo response as well. And we've always taken that as something that we're doing correctly, but having a greater depth of understanding about the placebo response may help us to crack some improvements in future areas of care. There's lots of work going on in endometriosis now, and I would direct you to things like the clinical guidelines for endometriosis that were released just this year, so that's from RANZCOG. I'd also direct you to the National Action Plan on endometriosis. It's coming to its end of its first 3-year course, so 2018 to 2021. And fortunately, the federal government has invested around about $22 million into endometriosis in the areas of awareness, education and research. And we're pushing very hard. I'd love for that to be $100 million. But look, if we got, $30 million every year, that then in 10 years, we would be as far as breast cancer is now in the area of endometriosis, with exactly the same number of women who are affected. Thank you very much for the invitation to the conference, and I look forward to fielding some questions in our question time today. See you later.
Thank you so much, Professor Abbott. My name's Maddie. I'm one of the academics officers for PVOGS ANZ this year. That was a very clear and comprehensive overview, so thank you for all of your insights. We do have a couple of questions that have been asked, but please feel free to keep sending them through if you've got more. One of the first ones we've got is sort of based on that early research you were talking about, where we've got good data showing how common it is and how many women it affects in Australia and around the world. Based on how difficult it is to diagnose, how underreported or underdiagnosed do you think endometriosis is?
Yeah, look, it's a really good question, Maddie, and it's one that comes up when we do these epidemiological studies. The very early studies that were done in this field were often done in women who were having a laparoscopy because of sterilisation. And so we were actually able to target much more broadly a population where we wouldn't go around now and just randomly laparoscope lots of patients, and the number of laparoscopic sterilizations has fallen considerably, as it certainly should. And so those early studies from the 80s and 90s, all of them showed about 10%. So that seems like a reasonable kind of figure where we were absolutely able to demonstrate the histological presence of disease. In the studies that have been done now, Stacey Mismer's group from the USA, and Ingrid Rowlands and Geeta Mishra, who led our study here with the Australian Longitudinal Women's Health Study, what we did was look not only at the diagnosis made laparoscopically and match that into surgical findings, but also clinical diagnoses. And that's going to be things like how it might have been made up on imaging, and then drugs that may have been prescribed, so the GnRH analogues and the progestins. Now, all of that potentially could have some issues and some flaws. But one of the key things that I think is really important is this 10% factor has been present over and over and over again for decades and decades. So it seems like that's probably around about right. And whether you look at that early group of just making it surgically to now kind of this shift into more of the clinical diagnosis, it seems like that's probably about it. Could it be more prevalent and underreported? Look, that's a different conversation, because it's about, is this presence of disease versus disease plus symptoms? And, you know, this is a debate that's been raging forever in terms of endometriosis. If you've got the disease present but you don't have any symptoms, is it truly a disease? And should we classify it as a syndrome? And that's where one of the reasons potentially that we only make that diagnosis for women in their 30s when they're thinking about fertility. And that's a you know, an important factor, because they may go, my only symptom is I can't become pregnant. What we do know from that group is when you start asking them questions, they go, oh yeah, but I always had painful periods. That's normal, isn't it? Because my mother had painful periods, and I would tell her, and she would just say, yeah, but that's normal. I had them and you have them, so that's how it goes. I think that educational piece is now a little bit different. We're definitely seeing mothers bringing in their daughters at a younger age and said, I had a terrible time. I had a diagnosis of endometriosis. I don't want my daughter to have the same issues.
Absolutely, yeah. Another question, does an endometriosis flare always coincide with menstruation in a person with regular ovulation?
Yeah, look, it's a really good question. And I think this is potentially another myth in regards to endometriosis, because we always think that the ectopic endometrium is exactly the same as the utopic endometrium, and it's not. And so you don't have to look very far. And in lots of, you know, chat rooms on endometriosis, it's like, yes, you're menstruating on the inside at the same time as you're menstruating on the outside. That's not correct, because we don't have a basal layer with this, you know, growth under the influence of estrogen and proliferation and then shedding like we do with the utopic endometrium. And we know that there's often a dysynchrony between ectopic and utopic endometrium in terms of cyclicity. So they don't always grow and respond at the same time. What happens is you're still getting an inflammatory change. Now, the reason we most often will see exacerbations of pain at ovulation and menstruation is they're the times that you see the greatest peaks in eicosanoid release. So at the time of ovulation, you know, you spill all of this beautiful fluid out from the follicle, and that contains a really high concentration of eicosanoids, which then can cause nociception in and of themselves. The same is true around menstruation. The progesterone plummets, you get vasoconstriction, so you're getting the vascular effects, you're increasing your eicosanoid production, so you're getting the inflammatory effects, but you're also getting the muscular effects as the uterus is starting to contract, the vagina contracts, the tubes contract, and then if you've got any other downstream effects where the muscles are causing problems, skeletal muscles that is, they can go into spasm as well. Now that can happen at any time, and just like any inflammatory disease, a time of inflammation anywhere in your body may cause it to flare. So we need to get away from thinking, oh, this is menstruation and I'm menstruating on the inside. That's not how it works. It is an inflammatory process, but those two trigger points of ovulation and menstruation, the reason that they occur is just with those changing in your naturally occurring eicosanoid production.
Thank you so much for clarifying that. It's definitely a myth buster. It's something that we commonly see. Another question more about sort of post-surgical management. Given surgery doesn't always reduce symptoms for women, as you highlighted, how do you suggest we effectively treat these post-surgical patients, and particularly accounting for their feelings of sort of disappointment and desperation?
Mm-hmm. Oh, look, I think that's a really good question. The key here is to find out who is and who isn't going to respond to surgery. And so what you would do is those women who aren't going to respond, you wouldn't put them through surgery necessarily. So the way that I would always approach it, where we don't have all of the data up front now, is to try and work through and listen to the patient. So, a patient who comes through with pain used to end up with a laparoscopy. And they'd have their laparoscopy and you'd remove the endometriosis and you'd go, right, I'll remove the endometriosis and therefore it's all better. And they would say, no, it's not. But that's not always the cause for their pain. So listen to them and then try and understand what it is they're telling you. I've got dyspareunia as my principal issue. I've got dyschezia as my principal issue. Can you see disease in those areas? And does your surgery need to include much more extensive dissection and removal of those deposits? Because that's a different conversation. Does the patient give you symptoms that say, actually, I've got a neuropathic basis. I've got, burning of the vulva, and these symptoms can occur at different times of the cycle, and I'm not getting that classic rise and fall with menstruation and or ovulation, and I'm not responding to things like the pill. So that's when you might start to think, okay, maybe there's a neuropathic component here, and therefore an anti-neuropathic medication help somewhat in these situations. Am I thinking about a pelvic floor muscular dysfunction? Do I need to think about physiotherapy as a first-line treatment? So starting to tease out some of the things before you get into surgery. And then, you can get to the point where you say, actually, we've done all of those things and we're not getting any improvement, so a surgery might be appropriate. But it's about the conversation you have as well. If you say to a patient, I'm going to do a surgery and it's all going to be better, then that's a very high level expectation. So sometimes what you need to do is say, look, we can do a surgery, and even if we find disease, you may not get any benefit. And I'll go, yes, but I need to know, and I've done everything else. So that's the first thing. And the second thing is, targeting patients where you think they're likely to have a better outcome. And we know that for patients who have deep disease with dyspareunia, dyschezia, you can see the lesions in the uterosacral ligaments and around the bowel. When you remove those symptoms are likely to get substantially better. We demonstrated that through things like the randomized trials. What's not likely to get better is always their dysmenorrhea. But you can say, right, your dysmenorrhea is not likely to get better until we do things like the pill, try and get rid of that cycle. Remembering there's so many women these days who don't want to use any hormones. Totally fine. And you say, yes, but it's not all going to go away. So again, changing that level of expectation. And the third thing I think that's important here is if things don't get better, don't abandon them. Don't say, well, I did my bit and therefore it's not my problem. It is your problem because you've taken them on board. If you've done the surgery and it's not worked, then you need to think about why that is. So, I've completely flipped around how I would work now, gone back to very non-invasive things, work things through. Can we do this in a non-invasive way first? And you lay out everything on the table. Here's all of your options. So one of my other mantras is I provide, you decide. And, just lay out all of those choices and let the patient decide for themselves. But sometimes you say, I would usually start non-invasive here. And that can really help to decrease that sense of dissatisfaction and that sense of loss.
Absolutely. Thank you. We might just have time for one more question. And this one's a bit more about your practice in particular, just because it's quite clear that you're extremely experienced and have learnt a lot across your time. You touched on during your presentation the change that you'd had to your surgical approach over the last 2 decades with this change in, research and us learning more about endometriosis, or the group of diseases that is endometriosis. What other changes have you seen in your practice throughout this time? What are the main sort of clinical changes you've had?
In endometriosis? If we stick pretty much with endometriosis, I think the first thing is a movement away from hardcore heavy hitting drugs as kind of first line treatment. And when I was practicing in the 90s, lots of women were having, huge volumes of GnRH antagonists because it was sort of just been released. It was the new big thing. It was very trendy. And we've definitely moved away from that practice. We've got evidence that, things like the pill, progestogen, can make a difference. I think analgesia, the self-help stuff, trying to decrease overall inflammatory processes. So can we do things in a non-invasive way? I've also seen a big push towards things like diet and natural therapies as a way of controlling, changing the symptoms. And there's no doubt that I see lots of patients and they go, I've gone gluten-free, dairy-free, nut-free, taste-free, and my life is much better. And I go, I'm fine with that. I have no problem, but it's got to be sustainable. And so they've got to be able to do that forever. And if they're getting improvement in their symptoms, totally great. Is that scientifically based? No. Are we ever going to prove that? It's really, really hard with things like the diet, dietary changes. And to do those studies and trying to control for everything is incredibly complex. I think in terms of surgery, the biggest change would be we used to always do two surgeries, a diagnostic procedure and then a therapeutic procedure. There is absolutely no reason to do that whatsoever. And it increases the risk. It does not increase the benefit to the patient. A good imaging study, ultrasound or MRI, depending on where in the world you are, make that diagnosis, get the team together, talk to the patient about what the risks are, and then do one surgery once and well. And finally, the thing that I think is really important is this checkup laparoscopy. And again, we used to do a laparoscopy and then 12 months later, we'll just have a quick look and check that everything is all right. Absolutely no way in the world should that ever be happening now. You never do surgery on the asymptomatic patient, and you need to be very cautious in repeating surgical procedures where there hasn't been a response. So gauging that response. And for me, if you haven't had at least 2 years, but I prefer 3 to 5, then, you've got to be cautious about whether you're going to do a repeat surgery again, because you may just be winding up that central sensitization and causing problems.
Amazing. Well, thank you so much for joining us this morning. It was a brilliant presentation and really, really good to hear your insights from speaking. I wish that we could, keep talking forever because there's lots more questions that have come through. But thank you again, Professor Abbott, and it's been
my pleasure
having you.
Thanks for having me, and thanks for the invitation. It's been great to be associated with the organisation. I wish you very best for the conference, and hopefully everyone will enjoy FIGO as well if you're going this week. So have a wonderful time and a great day.
Thank you so much. I'll hand over to Sam now to introduce our next speaker. So Sam, if you want to take over.
Thanks, Maddie. That's perfect. Our next speaker is Professor Caroline De Costa. Thank you so much for joining us, Caroline. I think she's there.
Yes, just unmuting.
Perfect, thank you.
Pleasure to be here.
Thank you. So Professor Caroline De Costa is the first woman to become a Professor of Obstetrics and Gynecology in Australia. She has been a major contributor to Australian women getting the reproductive health services that they need and deserve. She is a professor at James Cook University in Cairns and the editor of the Australian and New Zealand Journal of Obstetrics and Gynecology, ANZJOG, author of 15 books, mother of 7 children. Her most recent book, The Women's Doc, recalls very funny and poignant stories about her career and life. And a copy of this book is on its way to each and every one of you. Apologies that there's been a little bit of a delay in getting those posted out, but you shall all receive a copy. So after you hear Caroline's chat today, you can all go and read all the amazing things that she's done throughout her lifetime. So thank you so much for joining us, Caroline.
Oh, it's a pleasure, Sam. And thank you for mentioning that there are funny bits in the book.
Oh, it's hilarious. They're just absolutely fantastic. I was in fits.
There has to be some humour in it.
Absolutely. Do you want to start, Caroline, by telling us about your journey to becoming a medical student?
Yes, I must say thank you for the questions that you've sent to me. I've thought about them. So I was born and brought up in Sydney, and I finished school when I was 16, which was not uncommon at that time. The high school education just lasted 5 years. There was probably not so much knowledge around then. Anyway, I got into medical school in Sydney. People said this would be a good idea, and I did it, not really knowing much about being a doctor. And being a medical student was moderately interesting in terms of learning physics and chemistry and those things. It was much more interesting to follow some extracurricular activities. It was a hive of social change, political activity and so on that I was caught up in, and I began to have doubts about studying medicine. I finished the first year and then decided that I wanted to have some time off to get a job and particularly to travel. And at that time, this is end of 1964, everybody my age thought that London was the centre of the world. So I thought I need to make enough money to go to London. And I got a job on the buses in Sydney, on the double-deckers that went to Watson's Bay. And I was making quite good money, but it was going to take me a long time to raise the fare, which then was not an airfare. It was on a boat, P&O boat. And then one night in a pub, I met a young man, a New Zealander, a Kiwi, and he was on shore leave from a Swedish boat, a freighter, which was in Walsh Bay in Sydney at that time. He was a deckhand, and he was planning to go on this Swedish boat round Australia and then to Sweden through the Panama Canal. And he said to me, "You can get a job, you'll get there, you'll be paid, and you'll get to Europe." And I said, "Well, what will I do?" And he said, "Well, you'll wash the dishes." And how do I get it? Well, you look in the shipping news, which was the back of the Sydney Morning Herald then, and you see what boats are in, where they are, and you go down to the boat and go up and ask the captain if he needs any crew. So I'll skip over this a bit, but I did do it, and I did walk up quite a lot of gangplanks to a certain amount of acclaim from wharfies and crew members, but I did eventually get a job on a Swedish ship, and I did end up going to North and South America and to Europe. And I paid off the boat then, and that was in Greece, Athens. And I went, first of all, I got a train to Paris. And when I got out of the station in Paris, I realised that that had a pretty good claim to be the centre of the world as well. So I worked in France, I worked in Sweden. I also went to the Middle East. It was a very popular kind of backpacker route down through the Middle East. And it was very safe in the Middle East. It was before these terrible wars began. And by then I was thinking about actually doing medicine, getting back into medicine again, but I didn't want to come back to Australia. And in a girls' hostel in the old city of Jerusalem, I met a girl who was a student at Trinity College in Dublin. And she said, you could study medicine in Ireland. They speak English. So there was a fair amount of negotiation, and I took myself to Ireland, and ultimately I was accepted into the College of Surgeons, which is the undergraduate medical school, and it still exists, and it's very good, of the College of Surgeons in Ireland. And I started medicine again in 1967 and qualified in 1973.
I'm on mute, sorry.
Yes.
What was it like starting at Trinity College and being one of the only female medical students in a largely male cohort?
Oh, look, the experience was very positive. It was a very multicultural, multi-ethnic medical school. There were, for example, students of Indian origin from South Africa who couldn't study in South Africa, students from the States, a lot of Norwegians, because Norway didn't have a medical school, plenty of Irish, a very mixed bunch of us. There were 17 women and 100 men, so we were about 11 or 12%. But we were totally accepted then. The years of women being perhaps 1 or 2 or 3 in a whole cohort, that battle had already been fought, and there was never any suggestion that we shouldn't be there or that we weren't going to practice. And in fact, as far as I know, all of the 17 went on to become psychiatrists and pediatricians and ophthalmologists and things. We stay in touch very well. There was nothing that I remember that would be classed now as sexual harassment. There were certainly amorous liaisons between students. In the first 2 years, all the women were sat at the front. We had numbers, and we were marked off on a roll. You had to attend or explain why you didn't attend. So the women all sat at the front. But after the second year, they spread us alphabetically through the class. And at that time, my family name began with D. I sat next to the man who ultimately, I married and I became De Costa. Behind us, there were some M's who did the same, some S's. It was just simply, you're sitting next to this person all week. You kind of got to know them quite well.
How did you see that change, the number of women studying medicine and coming through medicine throughout your career?
Well, it's changed enormously, yes. And that's good. I mean, we now have, I think, about 55% of medical students coming in are women, and this has completely changed the profession. Certainly, they have tended to go into some different areas, into general practice, which is excellent because it's wonderful that families can choose or to see a woman GP and be well looked after. Certainly, we're seeing it in obstetrics and gynecology, to the point we are wondering if we should be somehow encouraging men to apply or feeling that they're not perceiving barriers to their applying. This is a question that RANZCOG is looking at the moment. They're getting into surgery now, women are. It's not easy. It's not always easy. I have a daughter who's in her third year. She's an unaccredited registrar, and she has told me some fairly amazing stories where misogynist remarks, critical remarks have been addressed to her. She is well able to handle it, as I think most young women now are who make decisions to go into various aspects of surgery. And whether we'll see an even greater increase in intake being female, I don't know, certainly. I've loved all the young women who've come through my 17 years of teaching in JCU. They're just so smart and beautiful and intelligent and hardworking. It's really been a pleasure to be teaching them.
Absolutely. And as you sort of alluded to, 1960s in Catholic Ireland was an interesting time. So can you tell us about your experience with the contraception train?
Yeah, well, there was a lot of extracurricular activity when I was in Ireland too. The Women's Lib had, the second wave of Women's Lib had come to Ireland. And of course, there were the Catholic Church had a stranglehold on the whole Irish people, the whole population. And there was certainly no abortion, there was no divorce. Same-sex marriage would have been, no one would even have thought of it. But also there was no contraception. It was impossible to legally obtain contraception in Ireland. So this was a problem. It was possible to buy the pill and to buy condoms in Northern Ireland, which was part of the United Kingdom. So the first real major task of the Women's Lib in Dublin was to protest about contraception. And one of the ways we did it was to catch the train from Dublin to Belfast, the usual train that went several times a day, and load up ourselves with condoms, and we thought the pill, we might be able to get it, and announced to what was then, the word media wasn't used then, announced to the press that we were going to bring these illegal things back into Ireland in order to demonstrate that they should be available to everyone. So we set off, there were 47 of us, and in Belfast we were able to get the condoms, but not the pill. We didn't have a prescription, but some of us bought aspirin and emptied the tablets into little bags. And we thought that the customs officers at the station, which is where we had to meet them, in Dublin would not know the difference, and they didn't. So we came back we went through two stations, Dundalk and Drogheda on the way, and there were women gathered on the station, supporting us, waving, so on. We got to Dublin and got off the train. We had taken some of the condoms and blown them up into kind of phallic balloons, and we were making a lot of noise, and we charged out of the station to be confronted by the customs. We were quite nervous, but the customs officers were much more nervous. Many of them did not know what a condom looked like. And so they didn't know what they were looking for. They certainly thought that we were swallowing the pill. And I was asked by one customs officer who would not look at me. Miss, have you got any of them things? And I said, yes, and scattered them on the counter. And he was deeply embarrassed. They took our names, they threatened prosecution and so on, but basically we had a lot more condoms than we declared, and we got very good press cover. And it was part of the beginning of the move to get contraception for Irish women. A more serious approach was taken by doctors who set up the Irish Family Planning Association. And I observed some of those clinics when I was a student. And then when I became a registrar and I was training as an obstetrician, I actually participated in those clinics. And for a while, there was the threat of police raids. Unfortunately, I was never in a clinic when there was a police raid. But after a while, there were moves within the Parliament, the Dáil, to change the law. First of all, only married people could have contraceptives, but later it became obvious that they had to be available to the whole population, and that eventually happened. And Ireland now has safe legal abortion, there is divorce, and there is same-sex marriage. And in some cases, these arrived in Ireland well before they did in the states of Australia.
Yes, absolutely. That's an incredible passage of history, particularly for contraception and women's rights over in Ireland and Europe. So you finished medical school over in Ireland, and then you decided to kind of get away from all of the paper trailing and charting medications that all of your colleagues had in store for them in Ireland, and you set off to Papua New Guinea. And then I believe you went back again as a senior registrar to Port Moresby Hospital. Please tell us about your time there. Why did you choose to move there, and what did you learn about your time over in Papua New Guinea?
Yes, well, we went there for internship. At that time, my husband and I graduated at the same time, the middle of 1973. I had been to Papua New Guinea previously as a student while I came back to Australia to visit my parents. And on the way back to Ireland, I went to PNG and I did a short elective in Port Moresby General Hospital. And so I had the idea that we could come back to Port Moresby General and do our internship, which we did. There were 6 interns. It's an enormous hospital. The number of beds there is fluctuating because you can always get another bed from out the back, and local people often wanted to sleep on mats on the floor anyway. But there were several hundred beds in Port Moresby General Hospital. There were 6 interns, so we had a lot of work, and as you've already suggested, not too much filling in of paperwork. It was completely different from the medicine I had learned in Ireland. So I had a pretty steep learning curve, certainly at the beginning. But it was fantastic. It was a great place to work. It was a great place to learn. It was a great place to feel that you were, even as an intern, possibly making a difference to some people. And so we felt that we would, having finished internship, that we would both train in the specialties that we wanted to. For me, it was obstetrics and gynecology, and for my husband, it was surgery, and that we would come back there. And we did come back to senior registrars in 1980 and stayed for nearly 2 years. At that time, the country had got independence, and there was a feeling that expatriates were not terribly welcome. And so we didn't pursue our idea of actually staying there for longer. And I ended up back working in Sydney for 17 years in private and public practice.
Based on your experience being over there, what sorts of advice would you give to people in Australia or in New Zealand wanting to make a change in a developing country like Papua New Guinea?
Well, I think the first thing you need to do is have an open mind and expose yourself to what is happening around you when you arrive, and see how people deal with things, often with very limited resources. And you need to understand why patients have presented when they have, what they're expecting, all that kind of thing, it's going to be very different from what you've learned in Australia. So you need to learn as much as to, I don't think you should have the feeling that you've come to change the world. You have come to share equally with the people that you are caring for. And I think a lot of what you need to do is impart knowledge to people who are going to, the people who live there, who are going to learn from you and continue to practice what you've taught. One of the things I've done in recent years is go with people like Dr. Greg Jenkins, that some of you will know. He ran groups of us went to different parts of Papua New Guinea to put in contraceptive implants. And there were, the last one I went on to West New Britain, there were several hundred implants we put in that time, but we also trained local health workers, local nurses, even local doctors in how to put them in and how to counsel women and how to take them out, so that when we left, it wasn't just a service that flew in from the sky and then flew out again. It was something that could be continued. And I do think that is important too.
It's about that idea of sort of capacity building to ensure sustainable care, I suppose.
Exactly. Yes. Yeah. Yes.
And so then I suspect a few years later you wound up back in Australia. Can you tell us about the beginnings of the first ONG clinic for the Aboriginal Medical Service and what that was like?
Yes, this was in 1991. The Aboriginal Medical Service in Redfern had been running for at least 10 years before that, but it was a general practice service, and it was very good, and I was aware of it. And I was asked whether I would come and do, I think it was twice a week, a clinic, antenatal and some gynecology, and there would be some relationship with Prince Alfred Hospital. I was not on the staff of Prince Alfred Hospital, but I knew people who were. So I said, yes, I would come. And I went and set it up. And I got a colposcope. So we set up a colposcopy service, which was useful. And it meant that women could come and feel culturally safe, even though I'm not Aboriginal. There were Aboriginal nurses, Torres Strait Islander, but mostly Aboriginal nurses and staff there, and it was a place that people knew, the AMS. But then if I had problems and I wanted to transfer someone to hospital, I had to call Prince Alfred and arrange that transfer. So I continued that until about 1997. At that stage, my husband and I were looking quite a lot at Cairns. I'm in Cairns right now. We had been to Cairns a number of times to do locums, and we were looking at moving here. And the Aboriginal Medical Service has been taken over by Dr. Sue Jacobs, who has now been there for 25 years. Unfortunately, has had to resign quite recently, but she has done a fantastic job. And she also had the advantage of being on the staff as a consultant in Prince Alfred, so she could provide really continuing and holistic care to women from the AMS.
And how have you seen Indigenous health sort of change and grow in that time that you were involved with the Aboriginal Medical Service?
Yes, so one of the reasons I came to Cairns was to be more involved in Indigenous women's health. We run, I no longer work in it, but when I first came and did locums in 1994, I began to do the outreach work. And that was the reason I came here. It was set up by Professor Michael Humphrey in 1992. So by the time I went in 1994, it was starting to become well established. He spent a lot of time before he set it up visiting the various remote communities and talking to people there to see how they viewed the idea and what they wanted, and making sure that we had close liaison with them at all times. So now the outreach service is nearly 30 years old. It's called PVOGS, Far North Queensland Regional Obstetric and Gynecological Service. And depending on the site, There may be 3-day visits. For example, in Cooktown, there will be a visit, which you fly up in a regular aircraft, and then you take a 4-wheel drive to go to 2 communities, Hopevale to the north and Wujal to the south. And so women can come and get obstetric and gynecological advice very close to home. And that was very important, and it improved greatly the uptake of antenatal care and the uptake of the colposcope goes and the ultrasound machine goes. So those things could be used. So there could be earlier diagnoses in many situations, and women transferred to Cairns as needed. Particularly, we still mostly transfer women for pre-birth at around 36 weeks. But the service itself covers the whole area from Innisfail up to Thursday Island.
It's a huge geographical area, and we're really looking forward to hearing from some wonderful women later about birthing on country. So we'll hold that thought for all of you out there thinking about that. We might move on. I guess, Caroline, you have demonstrated incredible ability to juggle multiple hats and multiple things at a time. You are the mother of 7 children that you kind of had at various points throughout your training. Can you tell us how you juggled parenthood and medicine, and what tips do you have for anybody wanting to pursue medicine and also to have a family?
Yes. There's a lot of juggling. I think one of the things that happened to me is that in my first year, when I went back to medical school in Ireland, I've already alluded to the lack of contraception. I became pregnant, and it would have been possible to go to England and have an abortion. I decided not to do that. My relationship with the father of my child there was no relationship. I was going to be what was then called in Ireland an unmarried mother. And I was going to have an illegitimate child, which I did. There was a lot of social stigma attached to that. But I, as an Australian who had not been brought up in the Catholic Church, had some distinct advantages. My family was not in Ireland. I have to say they were very supportive from Australia. But I didn't have those problems to face. The only problem I had to face was how am I going to bring up this child, this boy? And I became, I was very naive. I knew nothing about babies, nor did my friends. But I had to organise myself so that I took him to a small childcare. A woman really who ran a creche in her home. She was widowed, and she was wonderful. She became really a second mother to my son, and so I had to organise to get him there in the morning and then get him back in the evening, and then do all the things he needed and care for him, and also study. And it was just a matter of survival that I became quite organised. And so when I married and had the second child as a medical student, it was kind of established. And the others came, well, there's a more than 20-year gap over these children. So as we went on, I used different, when I worked in England, we had a nanny. They have a nanny who had been to nanny school. She was wonderful. She lived with us. And she was, we had a house in the grounds of the hospital, which meant that I could continue breastfeeding. I could go home for lunch and so on. And it was relatively easy to have her there at night on call, things like that. When we first went to a PNG, we had a nanny who came for a year from Sri Lanka. My husband's Sri Lankan. So I had someone living with us, which was good because the hours were very long working in Port Moresby. So I have always had people to assist me with care and housework and things like that. But you still have to be responsible for organising things, and you have to have, not only plan B, but a plan C and a plan D when things go pear-shaped, which they will do. You think you're going to have some time. I was once, I agreed to be part of a Lamington drive, which involved a lot of sticky chocolate icing and coconut and so on. And I was sure I had absolutely no problems likely to appear during the 3 hours I was doing the Lamingtons. And I barely started when I had a call from the hospital saying a patient of mine who had had real problems with infertility had presented with a ruptured ectopic. Well, trying to extricate yourself from Lamington making and get to the hospital turned out to be quite difficult. So that's the kind of thing that will happen to you. I've also been shopping in supermarkets and had to go to the checkout with a basket and say, look, I'm an obstetrician, I have to go and deliver a baby. Just look after this and I'll be back. So that kind of thing just has to be part of your life.
And having the kids riding in the ambulance and having the midwives help with the kids when you're delivering babies.
Yes. I've had a lot of help from midwives, and I've had a lot of children sitting in tea rooms doing their homework while being fed raisin toast by midwives. I love midwives. They have been extremely helpful. It's probably not a solution these days. Things are much more regulated, and you're less likely to find a place to do this. Yes. The other thing is when you have a number of children, by the time you have the third or fourth, you've got an older one who's able to do a fair amount, stack the dishwasher, keep an eye on the younger ones, keep them amused. And they do tend to look after each other. And there are, I think, less problems with children saying they want certain things, they won't eat this, they won't eat that, they don't want to wear those clothes, because you haven't got time for that kind of thing. You put on your school uniform, you clean your teeth, you pack your bag, and you go to school. There's no discussion. For example, in the households that I ran, because we both just had to get to work and get on with it.
Absolutely. Yep. As a one of four, I remember that very well. We all got each other ready for school and off to school. So that's exactly how it works in big families.
Yes, that's right.
So Caroline, let's put on your academic hat. Tell us about Anne's Jog and your role in research.
Well, yes, what I did in Sydney, first of all, was practice as an obstetrician gynaecologist, a generalist, which is what people were who I got my MRCOG in 1978 and my fellowship from what was then the Australian College in 1981. And people were all generalists, really. There were some people who were starting to go into oncology. There was no separate MFM, for example. The ultrasound was just starting to be used in the 1970s. So people trained. I did Wertheim's hysterectomies in the first few years when I was back here. I also did a reanastomosis of tubes in a woman who had changed her mind about sterilisation. And to my great surprise, she became pregnant in the right place. She had an intrauterine pregnancy. Now, none of that happens today. There are subspecialties. I was attached to a couple of public hospitals, but also I had private patients, and that was the norm in the 1970s and 1980s, with outside rooms and visiting medical officer privileges. There were very few staff specialist positions. If there had been, I think I would have sought to get one, because I think it is probably easier to manage a job like that where you're salaried and you also have set hours as a woman, but it really didn't exist. I had thought, I did most of my training in the Coombe Hospital in Dublin, which was a university hospital, one of the three Dublin maternity hospitals. And I had imagined that I would be in a hospital like that for my consultant life. And I missed the academic aspects of practice in Western Sydney, which is where I was practicing in the 1980s and 1990s. And so the possibility of joining what was then UQ but became James Cook University and moving up to Cairns was very attractive. And I had done an MPH. I then began to do a PhD. And in 2004, I was appointed as professor here, which I held till the beginning of this year. So I have done, I've become more interested in research, mostly with small projects. And I do feel one of the things that concerns me is that all of you who are going to become registrars and trainees of RANZCOG are required to undertake a research project. And I think you need to be doing that, not because RANZCOG says you have to do research, but because you want to find the answer that may improve the outcomes for women you're caring for. That needs to be the aim of your research. Even if you come up with a negative answer, that can be useful. So I've been interested in epidemiology, in the health of Aboriginal women and Torres Strait Islander women. I've been very interested in caesarean section and caesarean section rates. And obviously, I think, as most people know, I became very interested in abortion, in improving abortion services, improving knowledge about abortion for Australian women, and in increasing the options they had, and in changing law. So Anne's job, I was asked in 2015 to become the editor. They were desperately looking for somebody to do it. And I thought I was only going to do it for a few months and there would be somebody much more qualified to do it than me, but here I still am. And I really enjoy it. And I learn a lot. I have to read a huge amount of incoming manuscripts, a large number of which are rejected immediately. But I really enjoy interacting with the associate editors, reading other journals so I know what they're doing, picking out what we're going to do in each issue as we plan it. And I've certainly changed. It's now colourful, Anne's jog. We put colour in, we changed the font, things like that. More colour on the pages, which I think helps your experience of the journal. So, but I'm always open to suggestions for improvement.
No, absolutely. We were just reading the most recent article. I think you touched on a really important point about the importance of not doing research for the purpose of research, that whole publish or perish, but really finding something that you are passionate about. And we're going to speak later to Professor Permazel about applications to the RANZCOG program. And as we know, there are requirements surrounding research. And I think that makes it really difficult for juniors and people pursuing a career in women's health to feel that they need to meet certain requirements as a first author, whereas perhaps a more important project might not have such a junior person as the first author. So I guess what would be your advice to juniors wanting to get involved in research, and how would you advise them against, I suppose, publishing for the purposes of publishing?
Yes, well, I would tell them that they should avoid that. And I have now had quite a number of students, male and female, do research with me on doable projects which have made a difference. We've done work on fetal alcohol syndrome. We've done work on wound infection in caesarean section, for example, and a whole lot of other things where the student who has been in perhaps the 5th or 6th year of our 6-year course in JCU has found something that is important, and I would always allow that student to become first author because of this RANZCOG. And not only RANZCOG, that people change their minds about what they want to do and they go and apply for something else. Surgery, general practice, it's good to have a paper, and it's good if the student has done the work that they become the first author. I don't have any problem with that. I agree with what you're saying in that being first author should not be the criterion. It is whether the person, the applicant for traineeship is to understand how research is done and to be able to read research articles and make their own judgment about whether this is useful evidence or not. That is really should be the main point there.
Completely agree. Yes, I think that's really important that we all understand that going forward. Caroline, we've almost run out of time. If anyone has any questions, please, this is your last opportunity. I might just ask you one more question, Caroline, and if we don't have anything else, we'll finish up. Can you tell us what has been the most rewarding thing about your career in women's health, and where do you see the future going forward in women's health?
Well, I think being an obstetrician and caring for a woman who has either a difficult pregnancy this time or who has had previous difficulties, unsuccessful pregnancies in various ways, and watching over her during her pregnancy, during her labour, during her birth, or during her caesarean section, if that's what happens, and then having a healthy baby as the outcome is a really, really joyful experience. And even if it happens at 3 a.m., you are still able to enjoy it. And it makes the whole thing worthwhile. It really does.
It's that true womb to tomb care, isn't it?
I missed that.
It's the true womb to tomb care, as they say.
Oh, yeah, yes.
Well, Caroline, thank you so much. We are so grateful for your helping us today and speaking with us today. It's been really insightful, very motivating and very inspirational. So we are so grateful for you giving up your time. Thank you so much.
Oh, it's a great pleasure, Sam. Thank you for inviting me.
Thank you so much.
To all of you who are listening in and who want to get into training, either for the fellowship, but equally for those of you who are going to become diplomats and GP obstetricians. We need GP obstetricians, particularly in rural areas. So there are really two pathways for you there, or simply to be interested in women's health and do the certificate of women's health. There are lots of things that you can do and be involved.
Absolutely. Thank you so much, Caroline.
Yeah.
Have a really lovely weekend. Bye now.
Bye.
You probably all know about estrogel. It's an estrogen gel which is provided in a pump pack, and you get a metered dose of estrogen every time you press the dose of the top of the pump. Estrogel Pro is a combination pack, and it contains a packet of Estrogel Pro with 30 Prometrium 100 milligram capsules. It provides a month of combined body-identical MHT therapy for women who are using a standard dose of estrogel, which is 2 actuations per day, plus 100 milligrams of Prometrium per day, or 200 milligrams of Prometrium for 12 to 14 days if they wish to have a regular withdrawal bleed. That's pretty simple. Why would you use it? Well, a few reasons. First of all, safety. I've already explained to you that body-identical transdermal estrogen and micronized progesterone really seems to represent the safest form of MHT. Secondly, for convenience. Both the components of the treatment come in one pack. Thirdly, for compliance. They're less likely to forget one component if they have both delivered to them in the same prescription. And finally, last but not least, economy, because Estrogel Pro is at least 10% cheaper than buying the 2 individual components separately. Troubleshooting. For someone using a lower dose of estrogel, for example, say 1 pump a day, 1 actuation a day, then the pack of estrogel will last her for 2 months. And they will thus need a separate prescription for Prometrium capsules for the 2nd month before they revert back to Estrogel Pro prescription for the 3rd month. So what they're going to need is an Estrogel Pro prescription for the first month of treatment. And if she continues on on a single actuation today, you need to give her a separate prescription for Prometrium to get her through the second month. By that time, she will have used the estrogel pack completely, and she goes back to a new estrogel pro prescription for month 3, and so on. You should apply the gel daily, ideally at around about the same time every day, whether it's morning, evening, or the middle of the day. Apply one actuation to each limb, whether it's arms or legs, it doesn't matter. Don't apply it immediately after a moisturizer, but you could certainly apply it after a shower, and try and avoid sunscreen, because that will impair the absorption of the gel. Prometrium is best given in the evening. It may cause drowsiness, and poor sleep's a big problem for women in the menopause, so that's often a helpful thing. Not immediately after dinner, but half an hour or so before bed. The recommended dose of Prometrium remains the same for 1, 2, or 3 actuations of estrogel. And lastly, unexpected PV bleeding should always be investigated if it persists beyond the first 6 months. So I hope that's been a helpful explainer on how to use these products, and I hope you've enjoyed the talk. Thanks very much for listening.
Thank you so much. That was our lovely video from our sponsors at Bessons that we had a bit of technical difficulty with earlier. We've been running almost to time, but just a slight touch late. If everyone wants to have about a 4 to 5 minute break for a toilet break and grab a cup of tea or something to drink, we will get started with the next part of the program in about 4 or 5 minutes. Thanks.